unruptured the prevalence of aneurysms in our country is estimated to be about 3 to 5%, but very few of them rupture each year. So as practitioners, we're faced with the question, more of the aneurysms we see are going to be unruptured. So what do you do with them? So what is the actual risk of rupture of a brain aneurysm when you see it in the office? And there have been innumerable studies trying to answer that question over the years. There was a study that followed patients over decades to try to see if they ruptured. And the annual incidence in that study was 1.3%, with the cumulative rate growing as each decade moved on. And if you looked at some of the other longitudinal studies, the risks are somewhere in that range, 0.9%, 0.76%. There's certainly some variability across different populations. One of the main studies that we should all know about historically is ISHUA, and this was a unruptured aneurysm study. And this is the study that gave us the understanding of the different size categories for aneurysms. And it also looked at location as a factor for rupture. So most of us are familiar with that data. But at the end of the day, it only tells you about size and location. And there are some more recent ways to grade aneurysms, if you will, that really help us to try to figure out who should we treat and who should we not. So the phases score, which came out in 2014, it was derived from a pooled analysis of 6 different cohort studies encompassing over 8,000 patients. And in that group, 230 patients ruptured for a 1-year rupture risk of about 1.4%. And that makes me feel good when I see that, because it tells me, hey, we weren't way off base here. This is consistent with what we have thought in prior literature. But what did they do? They developed a rating score, if you will, and now we're not just looking at size and location. We're looking at age category, high blood pressure, the geographic location and background of the patient. So these are also factors that we have kind of known were important for years, and now we can codify them. And by the way, as an aside, it's sometimes, how do we remember all these different scales? Do I keep them in my head? Of course not. We have this thing that's attached to our hip called an iPhone, and you can go on the App Store, and there are any number of that you can download and use these scores on a regular basis. Not to endorse one in particular, I have the Neuro Toolkit on mine, and it has all of these. And you just pick one, use it, it takes 2 seconds. And that's helpful, I think, in terms of documenting for yourself, for the patient, in the medical chart, that you're basing your decisions on some kind of data and evidence-based medicine. So phases, you can see there the increasing risk of rupture, on a 5-year risk of rupture. But on balance here, you need to know your complication rate. So what is your personal complication rate for a pipeline, for coiling? If your complication rate is 2%, then you break even at a score of 7 over 5 years of risk. But if it's higher, then you need to think carefully about treating that patient with a 7. So that's the balance of that. So what's missing from those scores? Smoking. Smoking's a big issue in my state, in Kentucky. I don't know about y'all, but that's a big problem for us. Family history, comorbid conditions. So the UIAD score is a little bit different. It wasn't based on a cohort of patients. What they did is they took 69 specialists, had them look at 30 different aneurysms, each of them, and then rate what they thought was important about each case in terms of the determination to treat. It may be difficult for you to see up there, but those are all the different categories. Again, you just answer questions that you collect anyway as part of your H&P, and it will tell you, okay, would most of these guys treat this aneurysm or not? And that's really what it's telling you. And so it can be a helpful tool. But it lacks prospective rupture risk validation. So what about watching aneurysms for growth? And there's some data to suggest, as I've shown here, that if you see an aneurysm growing, that means that that aneurysm is less stable and more likely to rupture. In a study of over 1,000 patients, there was an 18.5% person-year risk if an aneurysm was shown to grow. So that is an issue, and I follow aneurysms for growth, but that's an issue of debate. We just heard a great talk on this issue, so I'm not going to rehash that, but it's certainly an area of growth and interest for us, and I think there's a lot more to be said about vessel wall imaging in the future. So what do you use? I think you just need to be consistent in how you evaluate your patients. And again, coming back to this issue of what are the risks in your hands of each of these modalities? Okay, how do you measure that? Don't just quote what was in the Webbit study. Know what your personal risk of complication is, okay? Track your outcomes, and there are tools to do this now. So for example, you know, there are nationwide databases where we collect endovascular outcomes and treatment modalities. Again, there are a lot of them, you know, different efforts going on there. Our institution uses NVQI. I think, you know, the important thing is that you track your data. And so here's an example to wrap things up of how do we incorporate new technologies and figure out how to do them safely. So for myself, this is an example, you know, of something that I recently did last spring, which is bringing Transradial to our institution. You attend a meeting, you do webinars. I did 50 diagnostics before I did an intervention. So taking it in a grade-wise fashion and tracking my complications very carefully along the way, I think that really helps us understand the balance between these rating scores and risk of rupture against your own risk of complication. So, thank you.